joined online. Hemophilia is a subject which, unless you have an immediate contact or you are in the field of providing care, there is a certain degree of mystery around it. So I thought perhaps I'll just give a brief overview and then we'll delve right into it with the experts. So the intent here is to focus on the exploration of new treatment options available. What are the symptoms, the efficacy of, and the comparison of the earlier treatments with the ones which are coming up. And very importantly, the 4 Ps, that is people, public, private, partnerships. How can they be leveraged and how can they help people as far as the accessibility is concerned, as well as ensuring that there is an increased awareness of this among the public. So without much ado, I would like to delve right into it and introduce our first speaker, Dr. Rajesh Kashyap. He's Head of Department, Clinical Hematology, SGPGI Lucknow, and State Nodal Officer, Hemophilia Management Program in Uttar Pradesh. So, what in your mind are the key clinical manifestations of hemophilia, and why is early diagnosis crucial for effective management? Over to you, Dr. Kashyap.
I hope I'm audible.
Yes, sir, you are.
Yeah.
Yes, sir.
So, ma'am, at the first outset, let me make it a bit clear. Now we talk not only of hemophilia, but we talk of hemophilia and allied bleeding disorders. When we talk in general hemophilia, it comes to the impression that this is a disease which affects primarily the males. So in the last few decades, we always talked of managing hemophilia A and B, and which were predominantly affecting the males. But now we understand there are subsets of other bleeding disorders which equally affect both males and females. So the focus of people dealing with patients with hemophilia now is changed. It's also that we try to emphasize women also bleed. And why I just started with this point is that women also bleed, that there are women who will be having a bleeding disorders whose problems are no less than a hemophilia. The numbers may be small, but at a personal level, the challenges in management of these patients are the same. So the World Federation of Hemophilia now also is putting a lot of emphasis on women with bleeding disorder. So I thought I'll take this opportunity that when we do a little bit advocacy, and this is a platform where it's going to in the public, that we should be able to tell our government and other people that there are women who will be having an inherited bleeding disorders who need to be also addressed to, and just not focus on males who are affected with hemophilia. So that's the basic starter point. Now the issue is that yes, hemophilia A and B is the commonest. Majority of them are males. In any country like India, our estimate is that there should be around 2 lakh plus patients who will be affected by hemophilia A and B, but only just around 30,000 plus have been diagnosed and registered across the country. So the first challenge is only 1/5 of the patients are diagnosed. The second point that we have noticed when we have been working is that in the West, majority of these children are diagnosed by the age of 1 year. But we usually are diagnosing these patients at age of 3 years plus and around 70% by 5 years. The reason for is access to the diagnostic facilities. The centers are limited. The centers which diagnose them are fewer. Now it comes to the family as to how do you create an awareness that your child maybe have a hemophilia. So you have a male child. The first symptoms usually will come by the age of 9 months to 1 year when the child learns to crawl or walk. So the child will trip over, fall. So he may lose a dentistry tooth or he may hurt his lips and the bleeding will stop. So normally a bleeding should stop in 2 to 5 minutes. If it persists even after you have put a cotton and you have pressed hard for 15 minutes and it has not stopped, then you should start thinking that yes, my child could possibly have. By the time 1 year and 1.5 years, the child will start walking, he might have a first bleed in his joints. So that is the first. So a male child who has a prolonged bleeding following an injury or a bleed into a joint should sensitize the family that yes, my child might be having a bleeding disorder and I need to go to a physician and get it evaluated. Yes, ma'am.
Perfect. So very interesting. You can pick them up as early as 1 year, but generally at 3 years. So we lose 2 years in between of being able to get them. So therefore, it's extremely important to have the advocacy in disseminating the information about this under the broader heading, as you put, of bleeding disorders. Now, what kind of complications do you see? So clearly, one is bleeding in the joints. Are there any, especially with regard to women, which one should be cognizant of?
I'll just come. If we take of the hemophilia A and B, 70% children or the adults which are there, the 70% of the bleeds are in the joints. Now, this bleeds in the joints will keep recurring. So, this over a period of time, the joint gets damaged, and then this is a major cause of disability in these patients. So, what we have observed in our own country, that 75 to 90% of our patients by the second decade of life have 50% plus disability as defined by the government. What is 50% disability? Which is a very high figure. Even if the number of the affected population is small, and of that population, if you have more than 75% disabled, then it's a real major challenge healthcare problem. The other sides of bleed, as I said, is following a cuts or an injury where the patient might bleed, and that has to be managed. Some of this, around 5 to 10% of patients will have a bleeds in the serious sites. That is, they might be playing and they get hit by a cricket ball or a football, or they are tripped over the basket and they develop a bleed into the brain, and we call it as an intracranial bleed. If it is not recognized in time, then it can be invariably be fatal in majority of these patients. Sometimes they might bleed in the gastrointestinal tract, and they may have a bleeding through the GI tract, or they can bleed into the urinary tract. So the fatality in these patients are usually a bleed into the brain, or what we call as a systemic bleed, either into a gastrointestinal or this. Now, when we come down to the women, which I was talking in emphasis, there will be subsets of hemophilia uh, carrier patients. We used to use the term carrier initially, that they are in a term that we know that hemophilia A and B is carried by the X chromosome, a single. So the males will have a single X chromosome, so obviously they get affected and they are manifesting. Women will have two X chromosomes, so the other X chromosome takes over, and the patients will have a low factor VIII level, but they usually not be. But we are now emphasizing that in these women who are carriers, menorrhagia is a major problem. So now, because of a cultural issue, they don't come forward. So we have a screening program in our own center for women who are carriers and with other bleeding disorders, and we find that it is a major cause of a morbidity in them. And because of the cultural aspects, they are hesitant to get it diagnosed, come forward and get treated, and this affects their quality of life in the form of education, getting employment, and working elsewhere, because they tend to bleed 17 to 18 days per month. So that is a major issue. It may look very frivolous for the person who is not involved, but if you are looking in from a women's aspect, then it is a major challenge. Yes.
Excellent. So very clearly, picking them up early to ensure that the disability is managed and does not affect the quality of life. And as you said, to address the social aspects around it, there needs to be a collaborative effort by all people concerned.
Yes.
So, if you were to say, given your practice and your exposure, what would you say are the two topmost pieces that we can take over and say we should now push for this and say? It's like saying when COVID came, it was like an onslaught of advocacy, information dissemination. So, for
So,
bleeding disorders, what would you suggest?
so now I have a 4-point program that we carry forward. The first is the awareness and the diagnosis. Now, if you look for a diagnosis of a hemophilia A, the average cost which we perform is around 2,000 to 2,500 rupees to confirm that this patient has got a hemophilia A and B. But for a family who is working on Manrega or a daily wage earner, even to get that 2,500 uh, is not a is a small. Hello, am I audible?
Yes, sir.
Yes, yes,
Okay.
please.
Yes, sir, you
Yes.
are audible.
Yes, sir. So it's not a small amount. The second is getting access to a center which is providing this facility. So what we have seen is that the average patient spends around 500 to 1,500 rupees just to go to a center where he can get these tests done. So you see, he has to spend around 4,000 to 5,000. So the patients tend to postpone it. So we are trying an advocacy wherein the government actually makes these tests free of cost, and it bears the expenses of the patient to be traveled via an NGO. That's the first point. The second point is, now the government is supporting us on the as a part of a treatment. That's okay, but it is doing a treatment plan. But what is more important is to reduce the disability in these patients so that these patients can complete the formal education. What I've seen in the state of Uttar Pradesh, that 70% of the patients are only achieve primary level of education. Middle and higher school falls down to 10 to 15%. And the employment rate of the patients who have completed the plus 12 is just around 5% to 10%. So you see, because of the disability, their formal education is incomplete, and because of the formal education, their employment is there. So this is where I think the corporates have to come in, and under the CSR, I have been pushing them to do a CSR activity so that we can these patients who are affected by disability also have an opportunity to get an employment, and that actually will address this emotional and social issue like self confidence, acceptance in the society, and being self-sufficient. So these are the three prongs which I think the government needs to look into it, also support us for that. And I think this is where the corporate organizations can come in.
Perfect, perfect. So that gives me a segue to Dr. Vijay Kumar. Dr. Vijay Kumar is the medical officer in charge HTC and nodal officer at the NHM Asadhara project. So, given by what Dr. Kashyap has said, accessibility in financial and accessibility takes care of everything. The center should be equipped, knowledgeable about it, as well as then comes the treatment part, the novel therapies that are there. So, what in your experience are the challenges in being able to access this, as well as access the novel treatments? Over to you, sir.
Ma'am, the when we started in 2000, actually our STC was started in 2014, and it was a very difficult job getting the administrative and financial sanction, because for the health services department, hemophilia is not a serious public health problem, and there were budgetary constraints also. There's absolute lack of awareness at various levels, at the layman's level, political, bureaucratic, and even medical doctors and other caregivers. There was lack of infrastructure in terms of lab diagnosis and factor management. As the previous speaker said, there were very few centers which were capable of doing a factor assay or inhibitor assay. And there was a lack of awareness for proper management also. Many of the doctors did not know how to treat a hemophilia patient. And there are very few trained personnel for the lab as well as for the management. And the lack of political and bureaucratic will and convincing them was a Herculean task. And our the same issues we cropped up when we and finally we started a comprehensive hemophilia treatment center in 2014, and we tried to introduce pediatric prophylaxis in 2015. As the state policy of hemophilia was only on demand treatment, it was difficult to convince the local body to sponsor a pediatric prophylaxis in 2015 and getting the financial sanction. However, we got it in March 2015, and 2015, and the patient's parents were also not receptive to, because of the fear of inhibitors. Because the fear of inhibitors, difficulty in compliance, and the efficacy of proactive treatment. This necessitated detailed one-to-one discussion with the patient to convince them of the need for a proactive treatment. We try to arrange the factor infusion days according to their convenience, with reminders in case of default, and supporting the families emotionally. Then again, having convinced the local body, then we tried with the state government. The state government, based on the success of the Royal Medicine Project, like our local body had named the project as Royal Medicine Project, and based on the success of the Royal Medicine Project, the government of Kerala, we submitted a proposal for state level pediatric prophylaxis, which was accepted by the government of Kerala. The meeting had also approved the rough proposals for the sickle cell anemia and thalassemia. Finally, pediatric prophylaxis was launched in the state in 2022. So these were the hurdles, which when we started. One, the lack of awareness on the part of especially the policymakers, then lack of awareness on the part of the medical personnel, on the part of the patients, and the lack of resources. And we got support from the government, from the NHM, National Health Mission, as well as the local body, district panchayat, which actually financed 50% of the project, and also started the first pediatric prophylaxis in 2014.
Interesting. So, would I be incorrect in saying that there is a role for counselors in this piece? Because this is a long drawn out piece. And as mentioned by Dr. Kashyap also, that there are even in the medical community, there's a lack of understanding of the problem statement as well as how to treat it. So some amount of hand-holding perhaps by counselors may be of use. And the other thing is, have we been able to leverage digital and telemedicine, which people are familiar with now? Will that help in addressing some of the issues?
If you yeah. Yes,
Please.
Dr. Vijay Kumar, please continue.
Definitely there is a role for the counselors, because there was stiff resistance when we started prophylaxis in 2015, and the patients, they all were making hue and cry about these inhibitors. They were all told by their previous people that frequent administration of factors will lead to inhibitors. So that their fear was actually allayed by the counselors. We had to do a lot of counseling for that, even to get for pediatric prophylaxis. And once they knew that this will reduce the annual bleed rate, work absenteeism, school absenteeism, hospital attendance and all, then they came forward voluntarily and enrolled in the pediatric prophylaxis program. And it started with 45 lakhs and it went to 1 crore. That is for the local body, only to those in the Ernakulam district, in our own district, because it is sponsored by the district panchayat. So counseling has definitely a role. Regarding initiatives aimed at improving the accessibility of the patients, definitely we had very few outlets. In 2014, there was only one comprehensive hemophilia treatment center in Kerala state. Then after the Ashadara project introduction, we had 3 comprehensive treatment centers, one at Trivandrum, one at Aluva, and the third one at Kozhikode, and the district daycare centers in all district hospitals. Apart from that, all the taluk hospitals, 78 taluk hospitals have got treatment facilities. So it has diversified the treatment program in Kerala this has definitely with all these it is being regularly monitored by the district nodal officers as well as the district coordinators, and weekly by the state nodal officer and state coordinator. The daily usage and stock is checked at the district and state level, and corrective action is taken. And this has helped a lot in decentralization of treatment facilities, definitely. And even coming to telemedicine, about which you asked, it was actually the best use of it was made during the COVID period. COVID period, when the e-Sanjeevani app was commissioned, the people used to get the prescriptions also. They used to air their grievances, and we could, even though physically we cannot examine, we could just judge by the from the show whether they have got actual bleed or not, and give the prescriptions which were honored by the local government hospitals. That was a good thing. But even before that, we had told the patients to inform us during their bleed and keep a photo of their bleeds. But then the compliance was not good for that request. So e-Sanjeevani proved very useful because we could avail the help of the police and other service organizations in transport of medicines to the patients during COVID. And again, following flood also, it was very useful. And involving the HFI chapters and service organizations can also help to improve the system. That is exactly what we have been able to do in the past 10 years.
Excellent. So the sense I'm getting is clearly finance is an issue. Counselors definitely have a role to play. Telemedicine and digital can definitely be leveraged to be able to make things happen. So there are different pillars which are coming about, but at the bottom of it is all about the literacy and advocacy for people to at least get to know about it. So I'll just shift gears a little bit and go to Dr. Jha for the
Yes.
treatment aspect. So Dr. Jha is a hematologist at the new Gardiner Hemophilia Hospital in Patna, and the MITHILA Hematology and Hematology Clinic and Hematologist SURAKSHA AROGYAM. So Doc, in the area that you are, given what has been said, as well as with the rapidity with which healthcare diagnostics, treatments are evolving, has the journey become such that it is becoming more affordable, or is it getting more expensive and complex because the kind of diagnostics require a different kind of laboratory? If you could just share some thoughts
So,
on that.
thanks for this great opportunity. I am feeling very privileged to see Dr. Rajesh Kashyap, one of my teacher of SGPGI Lucknow, after many years. So I am excited and emotional also. So coming to the topic, I am working in Hemophilia Treatment Center and also involved in the EDL tender process meeting in the State Health Society of Government of Bihar. And so I have a very closely monitoring or related to the diagnosis or management of the hemophilia patient, other bleeding disorder, as rightly said by the Dr. Kashyap. So allied bleeding disorders are also very important. As per the treatment diagnosis concerned in Bihar, like in New Gardiner Hospital, you have installed a stago machine, a coagulometer, and you are doing free of cost most of the bleeding disorder related assay or factor, even factor APT, APDT, Fibnogen, factor 8, 9 are done free of cost without any charge. And as Dr. Kashyap sir know, through the NHM, you are also getting the factor 8, 9 standard half life, EHL, and recombinant plasma derived, and even the factor 7 you are getting through NHM, through the State Health Society. So we are giving the factor from last 1 years continuously. Factors are available without only 15 days or 1 month. Sometimes gap occurs, but usually factor supply is not continuous. And if the patient during the treatment or before the treatment, if there is a history of inhibitor, they are also treated with factor 7. And although I have no fever, but factor 7 is available continuously. So the treatment aspect, as a social scientist, as a person, awareness is very important, because with a better development infrastructure, road connection, patient could travel from village to district hospital, other referral center, and that is not major issue. But and the financial issue, especially in state of Bihar, is not a issue. That could be issue in AIMS or SGPGI Lucknow, because they are charging for the test or the. But in Bihar, even in Patna Medical College, they could get the factor test without any charge. But if they could have to get it done from AIMS Patna, they could have to charge 1,200 to 2,000. So but as for the prophylaxis is concerned, it is still very challenging. Challenging because it is not only matter of factor availability, or there is other many issues, like there is chance of loss or sati, and the patient could not come every twice a weekly, or thrice weekly, or in the case of hemophilia, even weekly to the hemophilia treatment center. So home treatment could be one of the options. So patient could be given a factor for home treatment, and they could take the factor at home. Then the compliance of the prophylaxis would be better. And but for that, patients should be more honest, attendants should be more honest. They could must have some training, self administration. These are the issues, or because in each and every village or kasbah there is a compounder. They are a very trained one, because they are treating other diarrhea or asthma like patients. They are giving factor without any problem. So even the recombinant factor could tolerate the temperature, very high temperature, sometimes 40 degrees C. So temperature of freeze is not no issue as it was with the plasma derived factors. So, but other issues are now coming, because with the more and more diagnosis or Bethesda assay that is not available in Bihar, you are getting done from other uh, laboratory. Although the Patna AIMS have started Bethesda assay, so more and more patients are now diagnosed as a inhibitors, and but before the diagnosis of inhibitor, there are so many complications could have occurred, as you know, target joint problem, disability, pseudo tumor formation. Sometimes they present with intracranial hemorrhage, as sir has said, with melena, hematuria. These complications are frequently seen, because I see 10 at minimum 10% daily, and 80% is in my center is 500, and total registered case as per society data is 2000. So all type of complications we are see try to manage. But in the case of hemophilia treatment, one thing very important: if there is any history or hemophilia in the family, a newborn is born in the last week, we just diagnose a case within 1 day and save the life of the a baby, because that baby has a history of had a maternal uncle history of hemophilia A. So it was he was diagnosed, and intracranial hemorrhage has occurred and treated well. a patient is safe. So these things are very important. You must have a emotional feeling attachment with the patient because other people are not so much concerned. And I, as a hematologist, try to all these things. If there are any other question, I would like to give the answer.
Thank you. Thank you. It's extremely heartening to see the progress that has been made, as well as the way you are being able to take care of this. So clearly, a shift has taken place in the treatment, in which the accessibility, as you mentioned, for the medication. But one very interesting point that you brought out, and that is home care. And you seem to be very confident that this home care can be given by the existing, as you said, compounders, ASHA workers, etc. The issue is to get the parents to agree to doing it, as well as monitoring them themselves. So again, it comes down to how do you counsel caregivers, what kind of counseling you give, as well as what kind of an emotional support you give, so that they don't run into the disability action. I think Dr. Vijay Kumar, you want to come in with some a point?
No,
Please.
because we had, in fact, we have 1,142 patients registered with us, and of the 1,142 patients, we had trained 318 patients or their caregivers to give self-infusion. We have trained 312, and it was going on smoothly till a couple of years back, when we were told by the state nodal officer that we are not permitted to train or advocate home therapy. Intravenous infusion by a person who is not professionally trained for that. So that is why it was stopped. Our home therapy was very well appreciated by the Newcastle upon Tyne team, with whom we had a twinning, and the twins, we got the best twin award also in 2020. They had in their report to the WFH commented very positively on the home therapy which is being adopted at STC Alua. But for the last couple of years, we have stopped doing it because we had the instruction from the state nodal officer, NHM, not to advocate home therapy. I don't know the legal aspect of it, but then giving intravenous training in intravenous infusions and giving intravenous infusion by layman is not permitted. That is what maybe Dr. Kashyap can.
If I'm permitted, can I just come in? Yes.
Yes,
Please.
please.
Uh,
Yes,
yes.
yes.
There were things raised by Dr. Jha also. Most important fact which I would like to emphasize is the cost. The disease, the number of patients is small. It's like a banyan tree. The number of patients are smaller who can be under the banyan tree, but the cost is like a big banyan tree spread over last. Means small number of patients, but the cost is expensive. The reason for it being expensive is that 99% of the drugs are imported. Only less than 1% of the drugs are manufactured in India. So that's the dichotomy, that we have got a very strong pharmaceutical industry. We have got the technology to produce recombinant drugs. Oncology is seeing a vast expansion, a very rapid. We are producing bio, but we are not actually getting our industries to invest in producing factories. That's the one take home message which I keep telling the major players who are there in the bio pharma industry, that why don't you think of this? Then the cost will come down. The second is, how much is an average cost? So let's say if we have a 50 kg patient who needs to be given a factor rate, then approximately per unit of factor rate comes to 6 rupees to us at the government rate per unit. So the patient would require uh, around say 3,000 units. So he's spending around 18,000 rupees per day. So this may extend up to 5, so 1 lakh. So which is a beyond to reach of an average patient in any way. So because the government is subsidized, we have been able to raise the quality of care in our patient. Now, if the patient develops inhibitor, we have only got 2 agents which we can use, that is factor 7 or FIBA, both of which are imported. And the cost then rises tenfolds. To treat one patient with one inhibitor would approximately work around to say around 25 to 50 lakhs. If the patient has to undergo a surgery, I had a patient in the last, three patients in the last year whom we had to, with inhibitors to perform a surgery, we had to spend around 5 crores of rupees. Now, when we come to the budgeting with the government, I don't fault the government. The government is right that for three patients, you want to spend 5 crores or 6 crores, which is exorbitant. This could be the average budget of any district hospital anywhere in the country. So, so the government's priority is maternal health, infant mortality. And I take what Dr. Vijay Kumar said. I was very happy to know that the district local body is supporting him. When I discussed this with an NHM, that the budget outlay for Uttar Pradesh is same as that for Kerala. So he said, Doc, it's very simple. We give a total budget. Kerala doesn't have a very high infant mortality or maternal mortality. So they can give more outlay for your hemophilia. Whereas in the state of Uttar Pradesh, the maternal mortality is very high. So we have to support that. Infant mortality is very high. Support that. So hemophilia care comes down. So when a health sector, a person sitting over there does the planning in the government, he's absolutely right from his view of aspect. But when we look from our aspect, is there. So the next thing I worked on it and I said, how do you do? So I took the factor rate. So I was informed that for the factor rate, we pay around 5% GST. For FIBA and factor 7, we pay around 12% GST. So I said the government said that for cancer drugs and for rare disease drugs, it will attract 0% customs and the GST will come down. So I asked the corporate organizations who sell these products, okay, why don't you do the advocacy and lobbying with the government that there should be a flat GST and why 12%? Because that 12% makes a huge difference. If a one vial of a factor 7 costs 80,000 rupees, a 12% GST adds so much high. So probably I raised this issue because, ma'am, you are from the CII. You can actually take over and then do with the lobbying that, especially for rare diseases, which the government is very proactive. It has got a policy. It has said 0% taxes, 0% GST. So somewhere, even for a hemophilia, this aspect has to be taken because if the cost comes down, the cost of treatment of the patients will also go up. And the second point is that Indian pharmaceutical industry, which is a robust and it is a story which is replicated and discussed world over, I think they should also start looking at diseases, rare diseases, and manufacturing drugs for them, and does not be confined to those groups which is profit making. Yes, managerial economics says that you do it in that fashion, but then sometimes there has to be a CSR responsibility and you should invest some amount of money on research on this side and look after that. That's what is my advocacy now with all these years of experience and working in hemophilia.
Thank you.
Sir,
Thank
Sir,
you. I
I had
yes.
sir,
sought an advice from you whether it is needed or not, home therapy.
Uh, no, sir. When I wanted to do a home therapy, as you rightly said, the NHM raised a red flag and said that we are only going to support only the on demand. And then I did a economic study. And in the economics of it, maybe this is not an audience wherein the time is short. We could share with that. And I said, actually, home therapy works out cheaper because the patients don't have to travel. You need
Exactly.
to have a very strong monitoring system. So for some patients which you have done, I just learned it from some other states that you give the patients the particular vials, they come back after 2 months, deposit the empty vials, and take the fresh 8 vials like that. So it requires a lot of logistics and planning. So as a doctor, we have started learning the managerial principles, looking at the industry and the business managers who come and meet us. So some amount of MBA by practice is what we also are learning as to how do your supply chain and how do you do your logistics and address those uh, issues that it comes in a program implementation. So
Yes. No,
that's the
I
challenge.
Just to add a home
I
therapy.
just
These,
I just come back to you, Dr. Chandra. Like I
yeah,
have a
yeah.
lot of questions for you. So, to some of the points that you mentioned, Dr. Kashyap, yes, definitely a lot of advocacy has to be made. And the points that have been made for home care, this is what we all have been rooting for a very long time. The only way to bring down the cost of care, as well as to ensure accessibility, there has to be some loosening at the end of the day. The physician assistant course, the nurse practitioner course, all these are there. However, the system, the legal system is not supporting, and from CII we are all working That's it. Your comments on the pharma industry are very well. We will definitely take it up. The landed cost of a product when it comes right to the patient, we call it the waterfall effect. It's huge. It's huge. So I think this is well worth a place where we will work on and then get back in circle with you and then have a policy paper for the advocacy of that. Now to you, Dr. Chandrakala. So Dr. Chandrakala is professor and head of department, clinical hematology. She has a fellowship in leukemia and she's working at the KEM Hospital, principal investigator for national and multinational clinical trials, medical associate of International Hemophilia Training Center. What better person after listening to the entire discourse for you to fill in the gaps in this, to apprise us very clearly the efficacy of the newer drugs is well established, as well as the use of it, as well as the training. So over to you, Dr. Chandrakala.
Yeah. Thank you very much for the opportunity and nice initiative actually to make awareness about hemophilia. Regarding the new therapy of hemophilia, we have a lot of factors already. Everybody elaborated regarding the factor 8 and the factor 9. These patients lack these factors. That's why they bleed spontaneously. And we have a standard of life factor which acts for only 12 hours, which we have got extended of life factors which acts for longer time. And one good thing is we are also initially we were not getting the factors. Factors were not launched in India. They were launched maybe a little later, a few years after that. But even now we are getting the products. Newer products are also almost simultaneously, or as soon as it's launched in the Western countries, is launched in India also. So that's one good news is that patients are getting a better treatment now. And extended of-life factors are which acts for longer time. So that helps the patients on prophylaxis, they can get less injections. And apart from the factor 8 and factor 9, we have other actually factor called as non-factor therapies, novel therapies in hemophilia. These novel therapies are a lot of clinical trials are all going in India because we have got a second largest number of hemophilia patients in the world. Many multinational companies are interested to conduct the trials in Indian patients. Also, usually they are phase 3 trials. And coming to the normal therapies, we have got non-factor therapies. In non-factor therapies, which mimic the action of factor 8 or the factor 9, but they are not exactly factor 8 and factor 9. They are non-factors, they are monoclonal antibodies. At present, we have something called emicizumab, which is marketed in India for the last few years. And there are other novel antibodies which are in the clinical trial. And we have other consumab, which is also approved for hemophilia B with inhibitors. It's not yet available in our country, may be available in soon for our patients also. And in clinical trials, we have fitusiran, mimate, different type of monotherapies or monoclonal antibodies are available. So in the next 1 or 2 decades, the hemophilia patients will have a better options of treatment because multiple choice of drugs will be there. And because there will be a competition among the non-factor therapies, all the drug cost will come down for our patients. That is one good thing is in the next few years, we will have a better treatment options. Coming to the home therapy, which is a discussion, we started home therapy in KEM way back in 2015. I suppose we were maybe the first center to start the training in hemophilia patients, mothers. It's not the local doctor or anything. It's the mother or the father has to learn. If the patient is little older, more than about 8 years or 9 years, we used to train the patient himself to give an intravenous injection. Our Maharashtra state doesn't agree for the prophylactic therapy. So whenever we get support from World Federation of Hemophilia, that factors we give as prophylaxis. We still continue to give home therapy in our patients. But only problem we face is biomedical waste disposal. That everybody has to be careful, biomedical waste disposal. We give factors to the patient when we have a stock from WFH donation. They have to get all the vials, syringes, needles, whatever they use. They have to get back everything to the hospital and be disposed in the hospital. And it is not the training or parents learning doesn't depend on education. Our first mother who learned giving injection is illiterate. She could only Uh, uh, because she had 2 children of hemophilia, she learned to give injection as early as about 4 to 6 weeks. It's such an easy thing. It's if we can all train the patients. It's easy. Patients or the parents, it can be done. But there's no uniform policy of prophylaxis. Still, we are giving on-demand therapy. It doesn't change the nature of disease. The government is spending a lot of money on the treatment, but we have to start prophylaxis at some time. I think everybody has to do a awareness camping regarding prophylaxis therapy is the best therapy, and the government has to accept for that, like prophylactic therapy should be started at least for the pediatric patients, and then we can change it to the adults. So that message is still not clear, and it is a standard of care, but most of the government doesn't allow us to give prophylactic therapy because of the cost of the therapy. And coming to the Indian research also, all of us give low dose prophylaxis. It's not like a high dose prophylaxis. As Kashyap sir told, it's like he's told about high dose prophylaxis. We don't give high dose prophylaxis, we give low dose prophylaxis to our patients, 10 to 15 units per kg, though it becomes cost effective therapy. Even in non-factor therapy, we have published a paper regarding low dose emphysema prophylaxis. Almost the cost will becomes 1/3 the cost of which is actually compared to the standard recommended therapy. So it's our countries which we have to innovate different regimens which is suit our economically for and cost effective therapies. So it is all the research which we can do for the better treatment of our needy hemophilia patients.
Excellent, excellent. So you brought up the factor of contextualizing. Future seems to be bright. The price will come down. But what I find amazing is that you've been able to teach an illiterate lady as well as an 8-year-old to take care of it, which seems absolutely outstanding. I think we will get back to you on that to see how we can advocate for this for the rest of the country, so Kerala, UP can also start adopting it. So the interest of time, I can see the ticker going. I'll come to Dr. Aravind. He is MD Pediatrics, Assistant Professor, Department of Hematology, Institute of Child Health and Hospital for Children, Madras Medical College. So you've very patiently sat through the entire conversation. The problem statement is well articulated by everybody. Solutions seem to be there, but among everything, the low-hanging fruit that is there, if you could identify that so that at least some movement takes place in a positive manner, so that impact can take place for this very important community. And especially, as Dr. Kashyap said, we are looking at bleeding disorders as a whole, just not hemophilia, right?
Yes,
And what would be your opinion, as Dr. Chandrakala said, that you take young children, because there's always a flip side. You're teaching children how to take an intravenous shot. They are going to go about telling their other companions. What would that impact be? Over to you, Dr. Aravind.
Very good evening, everyone. And that's
Can you hear me, Dr. Aravind?
Yes, I could hear, ma'am. I think everyone could hear me.
Yes, we can hear you. Please do go ahead.
Yeah. Thank you so much for the opportunity, ma'am. It's been good to share all my experiences with the institute where I actually practice. We have a very good numbers. Like it is a premier institute. It's a research institute actually only for the pediatrics, that's for children. And I think everyone must have been aware of the Institute of Child Health in Chennai. So basically, we have around 300 patients which has been registered with us, like hemophilia A and B, around 50 to 70 people. So we do enroll them in the prophylaxis. We already enroll them. So hemophilia A, we have around 70 of them who's under regular prophylaxis. And hemophilia B, we have around 20 patients who's been under the prophylaxis program with us. So others in the entire state as whole, we have quite a large number. So we actually distribute them to those concerned districts where they could actually, like continue their prophylaxis. So mainly we concentrate on the prophylaxis program. So because we need to provide a good quality of life. So what we actually conclude is actually to give a better quality of life, and that is what we has mainly aimed at. So providing good prophylaxis actually would bring down the level of disability. So that is what primarily we think of in our mind. So it has been a wonderful program that was backed up by our government, and all the medicines we are in stock, and we stock them, for the next 3 to 6 months of time, so that we are not running out of stock of. So that's a very good thing. So the program runs very smoothly and effectively for a continuous period. And apart from that, like ma'am said, it's that low fruit. So early diagnosis is also one of the important factors. Like we could provide them, and then continue with the treatment. So like every match of my like many of them are seniors here, so I could take up their message. And has so prenatal diagnosis is also very important, that we have already done in our institute. So going for children, or the woman who's in a carrier state, or their like any family histories, or any sibling that is already one child is affected with the hemophilia, we do the prenatal diagnosis, and we have done with the chorionic villus sampling, and of course after the factor levels. So it is one of the important thing that actually makes this program run, and give the hemophiliacs a wonderful opportunity. And we counsel them, and we also educate them at the same time. That is more and more important. So like whenever they come for the prophylaxis, and when they're diagnosed, or new patients which have been diagnosed, we educate them in such a way that, so what are the treatment options, and how actually they could prevent, like much of them present with the joint bleeds and muscle bleeds, and they come across. So how do they prevent? These children are very important. Basically younger children, the parents have to take up, and whereas little bit older children, they were aware of, they avoid all these sports or contact sports, and they prevent themselves to have, not having this joint bleeds. So the backbone of us is actually the prophylaxis program which we run. And as Chandrakala ma'am was talking about all the latest, emucimab, we're actually going to take up this, actually the study, and we are going to put up here. So the drugs are ready here. So we're just going to start on our patients. So I think it gives a positive result. So coming back to the prophylaxis program, we also maybe to bring down the like factor need. So I think emucimab is a wonderful drug. So maybe these trials will help us, and maybe soon actually the Premier Institute will administer these drugs and have good results. Over to you, ma'am.
Thank you. Thank you so much. I think this has been an absolutely fascinating, at least for me personally also, and I'm sure for all the viewers, to see the amount of work and clearly the passion with which all of you are taking care of your patients. We are eternally thankful for that. A lot has to be done. It has to be done in a collaborative team effort, as well as putting one's wheel to the shoulder to the wheel, sorry, to make sure that the environment responds, and the good case pieces, the counseling, the home care, educating people and their caregivers. I believe these examples will also impact other chronic conditions where people tend to run to the hospitals when they can take care of them at home. So thank you very much for giving your time and sharing your views, and hopefully we can all work together to address some of these issues.
Maybe I can put in a last line.
Please.
So normally I emphasize on it that whenever we talk of hemophilia, I always say that we need to thank the government of India and the state governments, because in the last few years I've seen a sea change. The government has been very supportive. We as citizens forget to thank the government. The government is, I feel, they are proactive. All that we need to is to make our voices of hemophilia heard to them at the right time, appropriate time, and in the appropriate way. So I think the government of India and the state governments are due. Tamil Nadu should be congratulated for supporting a prophylaxis program, and I think we should take it as a case study and put to the government of India. These are the positive results from Tamil Nadu coming out. Thank you.
I think
Thank you.
that's a brilliant way to end it. And definitely, Tarini, peace to be shared widely. You're absolutely right. I remember some time back I wrote, we always say it's the government's responsibility. And I firmly believe that it's individuals' responsibilities also. We somehow love to share, let the ball be taken and the responsibility and accountability pushed onto somebody else. There's a lot that we can do, and I believe collaboratively is the way forward. So thank you once again, and thank you, Voice of Healthcare, for putting this together. Back to you, Tarini.
Thank you. Great, nice
Thank
meeting
you.
everyone.